Thank you. So we will start with today's session, and then I'll show the code book which all of you have shared. So I'll start with Dr. Hamid. He has given these codes. Like, I'm not going into the detail, but these are the list of the codes which he has given. Then you can see Dr. Mahendra's code. He has given these works. We have just put few codes in red color just to show how we have formulated the category. Then Dr. Pallavi has given these codes. Like again, high workload, we have colored it with green because we have made a category. So these are the like 25, 24 codes given by Dr. Pallavi. These are the codes given by Dr. Latika. And you can see like she has given these, we have put these in red color because again, we have made a category using these codes. These codes were given by Dr. Priyanka. You can see these like 21 codes. Dr. Mitasha has given, like you can see approximately many codes. I think she has done a great job of creating 71 codes. Then I can see Dr. Neha's code. Dr. Neha has also given us like approximately 27. Dr. Saurabh, you can see again huge number of codes like 74 codes. Dr.
Madam,
Tapobrata.
I have added a new file of code
Yes, Dr.
in group.
Saurabh, but actually we have included those codes which we have received till 9:30 because then we were working on your code book to make categories and all.
Okay, madam.
That's why
Okay,
probably
madam.
we have used your earlier version. Again, that's a good learning exercise, and you all can now, I think, after this exercise, you all are well versed in the process of coding, generating the open code. So this was Dr.
Madam,
Tapobrata.
the session is very nice.
Pardon? You said something, Dr. Saurabh?
Yes, madam, the session was very nice and I got everything what you have told and teach.
Oh, that's wow. That's so good. We'll listen from all of you at the end. So these are the like we have what we did total. If you count the number of codes, total we had 350 codes from all of you. So again, we said, and this is why the number is huge because we have taken number of codes from all of you. So that's why maybe we got so many codes. Again, I could not discuss the concept of solo code versus the team coding. Remember, I said that I will discuss. So before because it was a kind of, you can say, it was a team coding, which you all have done, like 10 people coding on the same transcript. So similar thing you might attempt if you have got not 10 people, but at least in attempt, we say that at least two people should do the coding, and then they should share their code book and decide either through a consensus way in during the process of refinement of code. The second thing, if there are multiple people, like 4, 5, 6 people, or maybe, then there should be one person as a code editor, and decision of the code editor will be final. So he might see the overall code, and then he can refine, and he will do the refinement process and deleting the unnecessary code and keeping the necessary ones. So probably you can say in your case, if we are collectively working as a team of probably 12 or 13 people for this manuscript, then you can say that we are the code editor just as a role. I'm just saying like as in a simulation, since we refine the codes, and we have reduced the number of codes from 350 to 70. So this is the final code you can see here. Uh, total of, if you can see the numbers, it's total of 69 codes we have like refined. So remember what we discussed yesterday, that when you see the individual codes, and then you subsume the smaller codes to form a bigger code, and then that's why you can see that you have got those and we called it as an iteration. So that's not the cycle. Remember, when you see your codes for the first time, again you see at your codes in the second time. So second time when you are seeing with the same eyes, it is not the second cycle coding, rather it is the iteration. So in those iteration, what you do, you basically refine your code, and you merge your smaller codes into a bigger code to reduce the number of codes so that it becomes manageable. Because 350 codes and fitting them into categories, it will be a huge task and it will be less manageable. And that then only right now, I think the total of 10 transcripts were there. That too only interview lasted for 10 minutes. So if you have got an interview, let's say 40 minutes or 50 minutes, even half an hour of 20 people, then the number of codes, the raw codes which you have created in the first cycle on the first iteration, it becomes very huge. So you need to do this exercise to merge the smaller code to make a bigger code so that the number of codes, it gets refined and there is a decrease in the number of codes. So that we have done this refinement of the codes. So you can see and remember, yesterday when we were discussing regarding the print PDF, there you always select the print in one row because then you can copy from that PDF and you can paste these codes here from the in the one line, because if it is in two column, then it will be difficult for you to have it in two column. So Dr. Latika is asking, refinement should be done at the individual level or while sitting together. So generally, what we have experienced, maximum of two people. So in all our publication, when we started earlier, two people used to code, and then we used to do it through discussion. So Dr. Latika, I think through discussion, when two people sit together individually, what you do, you code individually, and then you share your code book and then decide. That you can do. Or if you are a solo coder, that also not a bad idea. That is also a good idea. Because generally, if you see that if a postgraduate student is doing a thesis, he is or she is alone, so she does the solo coding. Yes, in case if you have, like we have a team here. So we, like me and Dr. Shamshad, main time we do it individually and then we discuss. So if you have got a team, it is good. Again, otherwise, solo coding is also good. In that case, you are in charge of your own data. That is also not bad. And we'll see in the this thing manuscript preparation. There are ways where you can define the roles. So no problem. Many times, especially in thesis and PhD, we have seen that it's only the student who does the these coding and the analysis.
True, ma'am. And most of the time, students don't know what's happening in the qualitative analysis that they're doing. So my as like reason for asking was the same. Because while you're doing the thesis, you're also simultaneously learning how qualitative analysis is being done.
Yes, you
Thank
are
you.
right. But in that case, like what we do, like what I do, or maybe Dr. Shamshad, what we do as a mentor, like we only tell them how to do it. They come to
Right.
us several times. But if
Correct.
we do for them,
Hmm.
for few students, we have done. Why? Because there is a submission time and the time is less. And they have, like, they came to us in the very last moment. Then there's no time to teach them. So many
Correct.
times we have done the analysis. But
Right. Right.
usually we try that they should learn. But
Yes.
whenever, even if you have done the analysis, you don't claim actually. You say that it's the student who has done it.
Yes, ma'am. True. Thank you, ma'am.
Okay. So any other, Dr. Abhijit is asking regarding something? Iteration process, yes, iteration you have to mention, like you have repeated, like you have refined the codes. Yes, you have to say that in the result, you can say the initial, you have like made a total of 350 or 400 codes. You have refined the codes in maybe 2 or 3 iterations, and then you have reduced the number of codes from 350 to 70. Yes, that's the way, because that's the process. You should definitely see and write these things. You will not find such thing written in many of the articles, probably. But again, what I believe, that whatever process you have done, if you write that, it is easy for the other person to see and learn how you have done it. So that's why I think you should write it. Okay, and ma'am, we have to mention that, I think. Okay, so now you can see this, like this is the refined code. You can see we have written this. Administrative inefficiencies, burnout among healthcare worker, communication skills are not prioritized in medical education, cultural barriers in communication, cultural hesitancy towards lifestyle changes. So these are the, and we have arranged it in, you can see as a alphabetical. So it is easy for us also because you can see that many like female and family, gender, these things, it's easy for you to make categories also. That we have learned in the QDA also. So this you can see, and then now you can do the categorization process. So we have made these Excel sheet beforehand, so that, but again, now in the process, what you can do, like you have generated a code, initial list of code. All of you have done that. Now the next task is to club these codes into categories after refinement. Definitely. After refinement, you need to club these codes into categories. So like in our case, in case of filaria, we had 15 categories of all those 50, 60 refined codes. And those 15 categories we made out of those initial code. In your case, like if you see these 70 codes, so maybe you can keep on. So this work usually we do in the QDA minor. But QDA minor, if you are doing it for the first, even for the second time, it is relatively difficult to arrange that into the category because you have to do many times. Like if the number of codes are much more, you can see here. Like if this list is too huge, most of the time I'll have to scroll up and down to shift it to some category. So before this, assigning categories on the QDA minor software, if you do this exercise on Excel, things become much easy. So how to do it? Like category, I have not named any category right now, but the similar looking codes, I'll keep on moving it into these categories. Similar, like let's say administrative efficiency. So if I want to, I'll cut this and I'll paste this in category 1. Then burnout among healthcare worker. Again, communication skills hai. So burnout among healthcare worker. This I could not, I don't think where should I keep it. So probably here I will write this as a administrative issues probably. And you can refine these categories also. If you don't remember the name or if no name is coming outrightly, you can just leave this as a category and then you can refine it later, the name of the category. So then I'll see now next category I can see cultural hesitancy, cultural barrier. So probably second category I will make as a cultural barrier. And then you can see here, I can cut this and I'll paste this code here in the cultural barrier. Then again, there is a cultural hesitancy. So I'll again cut this and I'll paste this code here in the cultural hesitancy. So similar, you can keep on cutting the code and pasting in the respective category. And that shows that, again, cultural influences. So again, I'll cut this and I'll paste this in the cultural influences. So these are probably the cultural barrier or cultural factors you can write. Then if you come down, now delays in administrative paperwork, delays in seeking treatment due to personal difficulty in accessing. So probably you can have one administrative delay. So this delay will be the administrative issue. So I will cut this and I'll paste this to the administrative issue and I'll paste this here. Again, administrative issues, you have kept it as category. So by seeing your verbatim, you can also classify few subcategories into the administrative issue. Why? Because when I was going through the codes, somebody has said that digital glitches here. There was one code of digital glitches. There were few people who said administrative work per se in the academics. There were few people who said that hospital administration, like delay in getting the supply, if OT is not prepared well, or probably if the things are not at right place, So those are the related to hospital administration. So administrative issue, you can again have some category related to academics or the related to hospital administration, related to digital issues or digital administration. So that will then it will be your subcategories. Are you getting my point? Till now, I have not talked of subcategories, but once you have a broad category of administrative issue, you can have some categories also like classifying further into. But that is only possible if you have coded in like a splitter code. That's why it is always desirable to do the splitting sort of coding, because then you can classify in each and everything. If you, since beginning, if you have kept as a very broad code administrative issues everywhere, then you cannot have those subcategories under that administrative issue. Are you getting my point? Am I making myself clear to all of you?
Yes.
So that's why, and again, since we have used your codes only to categorize, but since when you code it, you know well, and that's why there is a importance of making the codes, because you have to categorize these codes. So if you don't, like, if you just write patient care as a code, which we were discussing yesterday regarding the descriptive nature of code, but that code should convey some meaning to you, because every time you are not going to see what is written, like what is the verbatim under that code. So that's why you should have some keywords, and that's why if you do the in vivo code, even if it is a little bigger in name, that's okay, and then again you can subsume those codes and make a bigger one. But again, that hierarchy will be maintained. You will see that in the QDA minor, that you have got those levels like subcategories, theme and sub-theme, like that, and that tree you can make there. So you can see what all codes are there and what all codes are there. So that's why splitting type of coding is important in initially. Initially, I should not say, even we do till now also, we do the this splitting type of coding. Yes, lumper coding you can do if someone is narrating a story. Like if, like yesterday, I think there was one doctor who was narrating a story. So maybe if the narration of the story is like, let's say, in 7 lines regarding his experience, so in that whole narration, because it was the voice of one person, you can describe that whole narration with like one descriptive code, what it says. So that is regarding the lumper type of coding. Again, coming to the similar, if you see the other way, this is the other way also. There are two ways. So what I prefer this way, because then if you see this, I prefer this way. Why? Because I get happy seeing that number of codes here in this, they are getting less, and more of the codes are getting shifted into the categories. But there are other ways also, like you can do like this also. You can keep on making categories like administrative efficiency. You can write here like administrative efficiency. Just a sec. I need to do the, yes, administrative issue. Since I have done the, like this is workload and system. This we have done it. I'm just showing you right now. And this you can see like communication barrier, this as a probably the cultural barrier, or again, communication barrier, you can classify it as due to the cultural issues. This is again like cultural hesitancy, so cultural and social influences. So again, you can see these are the categorizations. So we have got these. If you see how many categories we have got like 7 to 10 categories. Healthcare system barrier, communication barrier, cultural influences, social and economic barriers. These are getting repeated. Okay, so we have defined 1, 2, 3, total of 7 categories. And out of those 7, and that is only on this less number of, less means like number of transcript are less, but generally we say that you should not have many categories. You should have, generally we say that in our transcript also there were 15 categories, which is like, again, a good number of category. And then we made 3 themes out of that. So if this is the category. So have you understood up till category, how we have in the iteration process, we have refined the codes. So we have reduced the number of codes from 350 to 70. Then we have categorized those codes in on the similar looking pattern, like falling into one category. And again, this will be different for different qualitative researcher. Your again eyes are different, your angle is different, your filter is different. So probably if what I am categorizing, not necessary that you will categorize the same way. There might be differences in the categorization, in underlying theory, what you think as a category, right? So this is just one way. Again, in qualitative, there is no right or wrong way. What you think should be is the best. You are your own best judge, and you are the in charge of your data and the this transcript. So whatever you think, the way it is, that way is good. And then once you have done this, then again you need to make a theme. So what is a theme basically? So theme is when you club the similar looking categories, or somehow you can classify it, then it is known as the theme. Like what we have tried to make a theme into, like we have made three main themes, like communication barrier in healthcare, the workload. We have clubbed two together, like workload and systemic challenges, and social and economic factors. So you can see we have made like these cultural and social influences. We have kept it in the communication barriers. So we have identified what are the communication barriers, and then we have tried to see the factors. What are there in the communication? Like what are the reasons of communication barrier? And then again, there will be one more theme, how it can be improved, because many of you have given the suggestion how this can be improved further. So that can be another theme, way forward, or tackling, or what should be the solution of these issues. So that we have not kept it here, but yes, you can do that. So this theming and all, you are doing it in Excel. Ultimately, you have to do it in the QDA minor. Excel, we have just told you, because here, once you have done it in Excel, now you have to convert the same thing here in the QDA. Why? Because you need the quote. Quote means verbatim. Verbatim, arrangement of verbatim and quote frequency also, because many times you have to give, like under which category, how many codes were falling, like mostly which category, most of the codes were like proportion wise percentage distribution you show. So for that also you need to convert the categories here. So have you understood up till this point? Then I'll show probably with the how we have done with the file aliases also. Can I see the chat box? Okay, Priyanka is writing yes. So you can see like this was the file code work. This was the initial code book which we have copy pasted. You can see there were many, but we refined. You can see how many codes, 137 codes. But again, we refined those codes. If you see the manuscript there, it is only the 50 refined codes. And then we have identified categories. Like I have written only the few categories here. There were 15 categories, but I have written only the 4 categories. And then we have shifted these categories here. Like in barriers due to the health, if you see the first one, due to the nature of disease. So the blisters in whole legs, the both legs, because the art central phenomena was the factors, like barriers in lymphedema management, and which is affecting the quality of life of the person. So these are the blisters and clinical features, fever. Now you can see here, I have written like, you can see there are 4, these are all raw codes. Like there are 4 codes with fever. Fever absent initially, fever more during winters, fever with chills. So all these 4 will be clubbed together as fever. So here I have not clubbed it. These are the raw codes. But yes, all these will be clubbed as fever. Again, you can see like here also it is written like headache. Headache is that okay? That will be in the clinical feature. So here you can see increased swelling of limb during summer, increased swelling of limb during winter. So I can club it like there is a seasonal variation in the pattern of swelling, or seasonal variation of swelling, something like that. Again, you can see the like pain in the affected limb, pain in the whole body. You can write like pain in the. So similar thing you can club it. So this is the way, once you have got like raw codes, then you can, here only you can like merge these codes and make a one final code. And same thing you have to repeat in the QDA minor. So this process can be done here also in the QDA. So QDA, you learned what all functions you learned yesterday, importing the file, creating the variable, then creating this spreadsheet editor, then creating this grouping descriptor, and then you have learned how to add code, how to,
Short code book.
yeah, good. Yes, sort code book, print code book, and then you have learned how to write your analytical memo or the reflections. And then once you are done with that, then you are going to make a category. Now, I'll show. So today exercise is what?
Ma'am, one thing I had a doubt with,
Yeah.
you selected one text and converted into a verbatim. Can you show us once again how you did that?
Okay, that was on Excel.
No, ma'am, in QDA minor light itself.
I selected one quote and then what?
And it was reflecting, that whole thing, a sentence was reflecting on the right side.
Okay. That what you do not see. If like this is the code at the beginning, I do not have fever. So if I want to select this thing in, let's say, fever. So I will select this, and if already there is a code, this generally if you have many codes, then what happens? Initially with 3-4 transcript, you generate codes and then later sentences fall into the same codes. So like if there is a code of fever, so if you select this and double click here, fever during winter, then it will appear here. Selecting the sentence, keeping your cursor on the code and double click on that code, then this code will be labeled to this verbatim or sentence.
Okay, ma'am. And how do you select the quote? QUOTE, like.
Oh, that is only select. You can like keep your cursor like using the mouse. The way you do in the Microsoft Word, it is the kind of MS Word.
And you're going to highlight it.
No need to highlight. You only select. You get the coding. If you go to the analyze, you will see that verbatim will be there under that. So no need to highlight. Highlight to we do it in the Microsoft Word, because that's not a software for analyzing the qualitative data. Here you don't have to do the highlighting. There's no way you can. I mean, there's no need to highlight. You will get those. See, the moment this red thing appears here, that shows that the whole this thing has been selected.
Selected. Okay,
Yes.
ma'am.
And we'll see today how to get those again, increase and decrease, yesterday which we talked.
Yes, ma'am. Yeah, that I remember.
Okay. Any other query before we move to next commands on QDA, creating the category and subcategory over here. You have seen in the Excel, but Excel you do it for yourself. If you have organized your codes, now the same thing you will do here by seeing your Excel, because in Excel organization is easy. So that's why managing codes first there and then writing again, converting those categories here in the QDA.
Ma'am, one thing is still not clear to me, that we have created the code like what Dr. Latika was asking. Now in this code, during writing my manuscript, I want to highlight the verbatim of the patient. So I have to read the whole paragraph and then I have to think about which sentence I had selected. Then
No. I have still not told you that. So please wait, because we are going like stepwise. Initially, I have only told you to do the work creating the open code and subsume the minor code to the broader code. Those things are still, I am just going to show you. But are you clear up till this point?
yes, ma'am. Yes.
Okay, then I'll tell you. Those things, there are a lot to learn still, lot to learn. Remember that quote from that school-going children. So yes, there is still lot to learn, and we will tell you now all those options which we have not told you regarding these verbatim, how to select, how to generate code frequency. That also I have not told you. How many codes in what category? That is still left. Okay, so I'm telling you. So if you guys are okay, then I'll move ahead. So let me see the chat box. Latika is saying yes. Excel sheet. Yes, Excel sheet I'll share. Okay, thank you. Okay, Dr. Shamshad has shared everything. So yes, if you have done till this point, now you have to create category. So how will you create category? Again, you have seen that these fluctuations, this will come under the clinical. If you see my filaria code book, that comes under the barrier due to the nature of disease. So I will write due to the nature of disease. So what I'll do here, I'll select and you go to the code and you press this edit code because initially there was no category. So what I'll write here, barrier due to the nature of the disease. So I will write here barrier due to nature of disease, or we have written inherent nature of disease. Nature of disease, right? And then press OK. So now you can see here at the end, this has appeared, barrier due to nature of disease. And then you can move these codes here, like swelling in one limb. So either you can go on again. I'm very bad in scrolling. So what I do, let me open this. I know. But I think that I prefer that way. Dr. Shamshad always do like drag and drop. But my mouse control is not that good. So what I do, I go to the codes and I'll edit it. And again, I'll select this barrier due to the nature of disease. And then I'll press OK. So this has gone. Filaria would not worsen after this happened. No, this is not fitting into that. Swelling of limb during fever. Again, if you right click here also, it will be like edit code. You can go here, select the barrier due to nature of the disease, press OK. So you can see the codes, those codes are now, if you come down, that has moved all these three, barrier due to nature of disease, right? Similarly, you can take like patient does not listen to advice of the relative, that will come in some other factor. Like long duration of filaria, again, it will go into this barrier due to nature of disease. Okay. And if you do this, let me try this. It doesn't go actually because the area is less to go. That's why probably there's an issue. So it's better you go like edit. And similar, you can keep on doing. So this will be, again, I can have some more categories here. So if you see this, there's a due to the healthcare system. So if I go here, patient not taken MDA despite being given, has no awareness about services at PHC. So if it is there, it is the health system related. So I'll go and I'll write edit code and I'll write the health system related barrier. So what I'll do, health system related barrier. Okay. Then again, treatment seeking behavior low, relative mind was becoming restless. Patient does not listen. Medical shop owner says that drug is of no use. These are like some other issues. Does not wear slippers if I in compliance to your non-adherence to compliance, non-adherence to the non-compliant to the advices. So probably a patient, this will become under patient factor, non-compliance or low adherence. So this will be non-compliance, okay. And then again, like this we have like does not use soap and all. This we have kept it as unhygienic, out-of-pocket expenditure, patient factor. You can see like BHM not aware regarding filariasis. Or BHM is a block health manager. So if he is not aware about the disease nature, or ASHA aware of contraindication for drug. Again, these are the facilitated factors. So you can go to the edit code and you can select from here like health system. It is not a barrier. So you can write like health system related factors So probably I will write factors. And then you can write like facilitators and barriers, because there are facilitators also. So if you have to write here, so what you do, I create a subcategory. So if you use the down slash is just above enter. So I have enter on your like keyboard. So use the down slash and write here that it is a facilitator. Facilitator. So I will put this. So now you can see here health system related factors. It has not come probably. Let me see, Asha. Just a sec. Oh, this one. Yeah, there you can see there is a plus and minus here. Let me focus. You can see there is a small icon here towards the left side. So these are the, if you like, if you click on this, this will be expanded. So health system related factor, they are the facilitator, and there will be barrier. So what I'll do, I will again put that. So I'll go to the edit code. This I cannot do. I will have to go to the code. This was a category. So what I'll do, I'll go to edit code, and I will again write this health system related factors. I will select this category, health system related factors. And then I can have again a down slash here and write barrier, and then press OK. So if you see this now, in health system related factor, there is a facilitator or the facilitating factors, and there are barriers. So under one category, you have created two subcategories. Are you getting what I am talking? Can I see any query? Okay. Latika. Now, if you can see here, if all the like categories are there in one view, probably then you can drag and drop. Mosquito net not availed from government supply in community. So this is a barrier. So probably if I select this and put this under this barrier, again it has not come. Yes, now it has come. So for that, in which category you do want to put, and that particular code that should be visible. That then it will be dropped. Like if I Asha aware about fallacies, that I have done. BHM aware. So it will come as a facilitator. So I will select this and I'll put this in this facilitator. Then you can see that then this drag and drop is effective when it is in the small area. But if you have to do like from the top and then drag it to the bottom, then it is difficult. So in that case, edit code option is better. So if you have understood up till this point, then I'll show you the final one. This I'm closing here.
Ma'am, please repeat once how to create the subcategories once more.
Yes. Subcategories.
Let me cancel this. Will it be closed? No, I have pressed the close now. I'm opening. Sorry, because it is in day 4. And I did not close it also. Stage 2, but I did not save it actually. I pressed no. Again, I'll do it. So since I did not save it, you will not see any of the categories which we have created. So it will be like open code. Right. So let's see, I will just do that system, health system related factors. So let's see, any swelling relative has no information. Let me come down, patient unaware, medical shop. Owner, patient not taken MDA, no awareness about services at PHC. So like this, I can go to the edit code and I can write open code as health system related factor, health system related factors. And then since it is a barrier, so I will do a down slash. Down slash, if you see your keyboard, where there is a option of enter, just above that there is a down slash. Can you see something like this?
Yes,
And
ma'am.
then you can write like barrier and you press OK. So then that category appears at the last, health system related, and there's a plus sign here. So if you click on that plus sign, you can see there is a barrier. Then again, I can see some more like Asha aware about the disease nature. So this I can go edit code. I can select the health system related factors, but again, it is a facilitator. It is because she was aware about the disease. So I can do the down slash and facilitating factors or whatever name you want to write. That doesn't matter. You can have it again. The way you want to do it, name, I don't pay attention towards what name I'm giving. That you can give any name. Only thing is regarding the process, how you create it. So you can then see like under this category, I have created two subcategories because I want to classify like health system related factors can be like facilitators as well as acting as a enhancers or as a barrier, whatever term you want to give. Okay. So have you understood, Priyanka?
Yes, ma'am. I have understood now.
Okay.
Thank you.
Thank you. So if you have understood this, I'm closing this and I'll show you a final version of this analysis, which we have like all categorized it. So I'll close this. No. And I'll write this stage 3. So similar, whatever process we are showing it to you, this process takes around, if you are working every day for 2 hours or 2.5 hours, or even let's say 1 hour, because you cannot keep doing the qualitative analysis from morning till evening, because you have to do many other work also. But spare some time, like let's say 1 hour every day, or let's say 1.5 or 2 hour every day. The most important thing which I want to emphasize, keep a log of your activity. Log means every day you write. If you are using an iPad, you can use some notebook there. If you are using a diary, write like day 1, what all work you did. And your reflections also, like analytical memo should be written then and there. Don't be lazy, like let me code everything and then I will write the analytical memo. Because that thought process, you are not going to come. Now your angle will change. When you are coding, you have got reflections. When you will you're going to in the second or third iteration, when you are refining your codes, then your brain is working mostly on the refinement of the code. Then your thought process will on the individual verbatim will not come. So remember, that's why keeping a log of like day wise, because that will help you in drafting the manuscript. Otherwise, you will be done with everything, and at the last, when you have to write, we will show you the SQC format of drafting manuscript. At that time, you may have, if you are very good at it, writing everything, that is okay. But if you are not very good, if you don't have a very good writing skills, then it will be difficult. Even if you have good writing skills, I will suggest you, because that thought process will not come again. So do maintain a log, day-wise log, what you did in day 1, and then you can see your progress also with time, how you have gone. This is very, very, very important, especially in qualitative research. And second is in meta-analysis. These are the two others you can skip, like other like scale development or quantitative analysis. Even if you don't keep a log, no issue. But with these two sort of technique of statistical analysis, log is must. Otherwise, you will be, in a soup, because you will not remember anything. The moment you leave your work for 4 or 5 days, then you will have to begin everything again from scratch, because you will be out of the touch. So please do keep this in mind. We had a very bad time. So that's why I'm saying you, we did not keep a log initially. And then again, now we are keeping. So maybe you do one mistake, then you experience, and then you will keep on doing. If you don't want to do this mistake, then please keep a log of it. So you can see here that barrier due to nature of disease, the symptoms and sign. And this is again, you can see like fever category. So you can see there are subcategories. Under this barriers due to the nature of the disease, we have created, this is one barrier due to nature of disease is one theme. Under that, there are symptoms and signs of disease. And under that, there is a fever category, which is subcategory. then pain and discomfort, then swelling, then red eyes, other manifestations. Then there's a disabler of quality of life. In the disabler, you can see low awareness in patients and relatives. And then you can see there are another like low adherence to the advices or medication. And then low health seeking behavior, hopelessness regarding getting cured from the disease. These are the barriers, disablers of the quality of life. You can see here, these are the disablers. And then you can see if you come down, these are again all disablers, non-maintaining personal hygiene. And then barriers related to healthcare system. You can see lack of capacity building in grassroots level worker, lack of receipt of regular incentive to grassroots level worker, unavailability of lab diagnosis. And then you can see later, enhancers of quality of life. So symptomatic management of filariasis. Again, you can see like safety netting at home and community. And then you can see like safety netting by healthcare system. So, and the awareness regarding the nature of disease in grassroots level worker. So these were like the, you can say like we identified 3 themes. Under those themes, there were categories, and under categories, there were subcategories also. So if I hope that this process, if you keep on doing, you will also modify your codes into the categories and theme. And then I am coming to the question of doing the content analysis in terms of code frequency. So what you do, so first thing is go to help, and like you did, like hide the full version menu, because that will keep your eyes focused on what you can do with this software. So go to analyze and click on this coding frequency. When you click on this coding frequency, there is an option here, search. This one, this search. So click on this search. And when you click, you can see, if I enlarge this, you can see the various count of the code. So these are the count. You can say like 4 to 1. These are the percentage, number of cases, and these are the percentage of cases. So you can see these counts. It gives you in the whole total codes which you have used, how many times each of the codes are there. So what you can do, like you can like compress this, because this is very huge. You cannot give this total to the in the manuscript. If you see the manuscript of the filariasis, you cannot give this table. So what you do, basically you give the frequency of the total number of codes in the category. So what we can do here, like you can identify one category here. Let's say this one, the first one, barrier due to the nature of disease. And then you can see, but you have to do this manually. There's no way like you can do this, or either what you can do, you can count this total and you know about the total number of codes. So let's say if total number of codes are 50, then you can keep on counting how many are there under this barrier in the symptoms and signs of disease. So it will be like total, you can count this and you can divide it by the total number of codes, and that will show the proportion of codes falling into this category out of the total number of codes. So this gives you the total frequency of the code. Now coming to other option, if you see this, and this is a tree. If you want to have it in table, this is like this. But again, table, again I said that it will be a very huge. So this cannot be presented in the manuscript. So now coming to another regarding the retrieval. So if you go to this coding frequency, press search and then right click this. So if you right click this, it will come like select item. And then you can select item in the barriers related to nature of disease, or probably if you want to write only in symptoms and signs of disease, or this. So if you select the upper, everything will get selected. So if you want to write like only on one theme, let's say if you want to write on low awareness in patients and relative, so you can select this, and then you can go to, again, do the right click. So twice you have to do the right click. Yes. Again, I'll do the right click and I will click on retrieve segment. If I press on retrieve segment, you can see I will have all the categories of this code, like the low awareness in patients and relative. And you can maximize if you click on this, there is a button. Just a sec. There is a button here. This option. If you click this will be in large text. So what you were talking regarding the verbatim, Dr. Priyanka. So now you can see. So whenever I have to write regarding this this theme or this category, I will open this and I'll keep like which quote I have to use. So this text, like I will just see what are the important quotes for me, because all the quotes I cannot use. So here, like some people go to medical shop and show their drug there, and that shop owner says that drug is of no use. So if you see this article, let me show you filariasis article. So this is filariasis. So under some, I think we have used this quote. If you come down, so see, we have given the quotes like this. Categories are only the major categories, not the finer one, like symptoms and signs of disease, the total number of quotes, something like that. And total is 156. And we have taken the frequency, taking the denominator as 156 quotes. Not much information. And I also forget to tell you regarding the triangulation. So triangulation as the, let me complete first, then I'll tell you the triangulation. Seasonal factor, see, this was the low adherence. Okay, low adherence, this was not used. Probably this we have used somewhere. I tried, I never go for consultation. I'll see whether I have, but apart from that, you can see like this is one theme, like one category of low adherence. And here I have triangulated the statement from three people. The patient is saying, I was taking another medication. How could I take this one? When they gave medicine, I thought I'll take it, but the same night I got fever and chills, I didn't take. So this was regarding the low adherence, which the patient is saying. Similarly, the caregiver is saying, he doesn't listen to anyone. He says it doesn't work, taking only those medications from private work. So this is again caregiver is saying this, and again one healthcare worker is saying, when I meet people, I ask them whether they took the drug or not. Few reply yes, while the rest say no. Most people don't take it in front of me, and I don't know what they did with the drug. So these are the three verbatim which we have used to show this category of low adherence. So this is known as the triangulation. Triangulation means like statement of the three sort of stakeholders showing the same thing. So you should try doing the triangulation in your manuscript whenever, and that's how it emphasizes on that particular category, that it is not only the one person is saying, like two patients, or if it is coming from all the three stakeholders, that there is a low adherence. So now coming to the, if you see this, yes, this I was showing you, you have to right click and retrieve segment. And let's say I want to use a particular, I am writing this. Sometimes this doesn't behave. It takes time. No. Let me do it with this. Well, let me close this again. If this behaves like this, you close the file and then again go. So again, I have go to code frequency, click on search. Let's say I want to write on the second thing, low adherence, low awareness in patients and relative. I go to the select item. I will select this. I will right click this, retrieve segment. This is not working. Should I close this whole again? Let me see if it does. Cannot make a. So you can go from that option also, the code retrieval, and then you can see this sentence we were using, like, who knows I am not educated. So in total, you don't have much information, just the injectable medication and nothing else. Just the injectable medication. And so you can see, I think patient, there are no, only I think this is the one important code which I would like to use. That, but some people go to medical shop and show their drugs. So what I can do, I can copy this to, I will select this. I will copy to clipboard. And I will do the selection. Copy to clipboard selection. And then I'll paste it. So let's say this is a Word document. I have pasted. So if you paste it, this will be appear here. This will appear here. Like, and then you have to use this double quote. And then write in the bracket, who said this. So this was the statement. So HCP Asha, healthcare provider, Asha has said this. So what I'll write here in the bracket, healthcare provider, or whatever name you want to give, Asha. Asha, I will not write here healthcare provider 1 because I don't want to use even an identifier. So I'll write HCP1, or you can write healthcare provider, the full name. You should not write the short form. Why? Because other people will not understand. Healthcare provider 1. And then this is how you can select the code. So is it clear? Dr. Priyanka, you were asking, I think Dr. Priyanka was asking.
Yes, ma'am, it is clear. Thank you.
Okay. So please repeat. What should I repeat? Okay, this was, I think, the previous message. So have you understood up till this point? Any query? Similarly, I'll show once again. This. Go to analyze coding frequency, press search. And then if you want, this will show you the coding frequency. Again, if you want to have the retrieval of the coding segment, either you can go from here. So for there, you have to select item, select this, and then again, right click and retrieve segment. It will come here. And this, if you press this, it will come here. Or else you can...
Hello, ma'am.
Yes?
I just came now. I had a lecture. Will sir provide this PPT or a video on the group so that I can revise it through?
So I think it is there every day. Every day we are
Okay, ma'am.
lecture.
Yes, ma'am. Okay.
You will have this. So this was the one. And if, like in this case, if you want to have like this chart, ultimately we don't show these distribution of codes and the word this thing, this word cloud. Many times you will see that people make the word cloud. So you can see with the font of what these chart option is here, where you can just show it. I've seen in few of the qualitative this thing, they show it with the word cloud. But this way you can only show with one of the probably. If you select all, I don't know. Here you can select like barriers of the disease. And then you can see.
Madam, whether in the word cloud, the size of the word is actually equivalent to the frequency.
Yeah,
Like
yeah.
some words are in bigger
Yeah.
font, some are in smaller fonts.
No, yeah, true. The words which are written in larger font, they have appeared more.
Yes, ma'am. Yes, ma'am.
True. But again, in this QDA minor, it is not that good. In Vivo, this word cloud is very nicely it's nicely drawn. Here, I don't think this much big you can like show. I put it in manuscript, so we have not shown it. But again, this option is there. So this because your word count increases very much in qualitative. Your word count goes up to like 7,000-8,000, and there is a limitation in the with the journals where you submit this regarding the restriction of word count. So that's why you have to be careful what all you want to write, or you can have your first drafted manuscript with the more words, and then you can later on trim it to the required number of words. So if you have learned up till this point, then I think we can have a breakout room where you can practice these 2 or 3 commands, making categories, making subcategories, seeing the code frequency, and retrieval of the code segment. 5 commands. And then we'll see how to do the write-up and few more. We have still not covered the second cycle coding method. We have still not covered the few type of analysis. So I think we have got 3 more topics to cover. So we are opening the breakout room. Yes.